On calcification, always a fun topic. I'm Rhian. I'm accompanied here today as my co-moderator, Stephane. And I guess everybody can maybe go down and just say your name. We can introduce ourselves. Starting with you, Ashish.
Ashish Pershad.
Pervez Mirage.
Jay Whitmer.
And Kostas Marmagkiolis.
And to our left,
Amer Alaiti.
Tom Tsai.
all right. So that's without further delay, we'll start the session with the first presentation, which is the year in review in PCI of heavily calcified lesion, and we have Salman, Allana, who's going to give us that presentation. Salman, go ahead.
Thank you. Thank you for the invitation. Thank you for having me here. So for the next few minutes, we'll talk about the updates in coronary calcification, what has been in the past year overall. These are my disclosures. So we've seen the coronary artery calcification has been increasing in prevalence. This is the data from the MESA registry of about 6,000 patients. And you can see that the coronary artery calcification initially in 2000, 2002, the patients with zero coronary artery calcifications actually slowly been declining. Patients with coronary artery calcification, the prevalence has been slowly increasing. And this has been due to multiple factors. This is the data from the ADAPT-DES registry of 11 centers that reported moderate to severe calcification, and about 30.8% of those patients had calcification. If you look at the IVUS data, about 76% of the patients have intracoronary calcification. And it is mainly all these factors which we commonly see in the patients with coronary artery disease are independently associated with coronary artery calcification. This is a very, very interesting topic and controversial too. We know that statins decrease risk of major adverse cardiovascular events. But the one way the statins do it, they stabilize the plaque, is by increasing the calcium burden of the plaque. This is the data from the CCTA paradigm registry of about 857 patients. And these patients had serial CT scans, and the plaque composition was assessed over a period of time. And you can see that with patients who are on statins in orange, they had decrease in the low attenuation plaque burden over time, decrease in the fibrofatty plaque composition over time, but their calcification, heavy calcification and very dense calcification plaque burden in the plaque increased. Whether this has any effect in the long term on the outcomes, we don't know. And calcium is bad, we know that. And this is the data from the Horizons MI and acute equity trials. Moderate to severe calcification has increased risk of major adverse cardiac events, cardiac death, and repeat revascularization. Calcified nodules, there's been more studies on the calcific nodules. This is the data from 657 patients who had IVUS-guided PCI. The prevalence of calcific nodule was about 5.3% in this study. And these patients had IVUS-guided PCI, and despite that, calcific nodules were associated with significantly higher risk of MACE, ACS, and target lesion revascularization. More data is coming up on eruptive versus non-eruptive calcification, calcified nodules. This is a study recently published of about 230 patients with calcific nodules. And you can see that patients with eruptive calcific nodules, their stent expansion was pretty decent, about 89%, as compared to stent expansion in the non-eruptive calcific nodules. So eruptive calcific nodules, the stent expansion overall is better. The eccentricity of stent expansion is better. However, despite this better stent expansion, they have the worst outcomes. Patients with eruptive calcific nodules, they have a significantly higher rate of target lesion revascularization and target lesion failure. The most other important thing that I want you to look at is this number, 18.3%. About 1.1 in 5 people who have had excellent stent expansion will come back to you with repeat revascularization in less than 2 years. So this is very remarkable data. And why is calcium back? And older data which shows that calcium is bad because it increases the major adverse events because of the decreased vessel compliance. Calcified vessels have 4 to 5 times less compliance than the normal vessel. And then to increase the compliance, we do these things to the vessel. We put in balloon at high pressure. Many times, the balloon expands the non-calcified, the more compliant sections of the artery and can cause perforation, dissection. There's a high risk of stent loss and stent under expansion that all increase the risk of major adverse cardiovascular events and complications. So not only perforation, dissection, but this is a very interesting case that I want to share with you. This is a patient who came in with a medically refractory angina and with a very severely calcified right coronary artery. It's tortuous, it's really calcified, we went retrograde. We're using a septal. We're able to, with a lot of difficulty, able to wire retrograde with the gladius mongo. There's a lot happened in the middle, but I want to skip to the part that we externalize the wire and it's stuck. So we externalized the wire. However, the wire got stuck in the right coronary artery. We could not remove the wire. We tried hard. We were not even able to get any kind of equipment down to retrieve the wire. And subsequently, can you help with this? Okay, great. So eventually the patient had to go for bypass surgery, and they had to do endarterectomy, the right coronary artery endarterectomy to retrieve the wire because the vessel was so calcified. So there has been renewed interest in the treatment of coronary artery calcification and the calcified plaques. We are all familiar with these devices. We have balloons, high-pressure balloons, modified balloons, OPN balloons, atherectomy, and intravascular lithotripsy, which has revolutionized the treatment of intravascular calcification. Recently, the problem with the cutting balloon and the angiosculp overall is they have a very high profile. Their crossing profile is about 0.041 to 0.046. However, with the recent, these balloons, the Scoreflex balloons, they are much lesser, have a lesser crossing profile of about 0.034. And they are unique in the sense that they only have one blade, and they have these have this proximal monorail port, which is proximal to the balloon. And so your workhorse wire acts as another cutter. So this balloon has actually been more deliverable and has provided the cutting effect. And this was studied by Dr. Kanzari and showed that in a single center study of about 220 patients, in which the procedural success, which was defined as the delivery of the device, inflation, deflation, with resulting in TIMI-3 flow and no perforation, was 93.5%, which is pretty high. We finally have high pressure OPN balloons available now in the US. They have been used for a while in the Europe. These are twin layer balloons that can go up to 45 to 50 atmospheres. And this is an older study that actually showed that these balloons can decrease diameter stenosis for calcified lesion and better for stent optimization in ISR. This was the results of the ISAR CALC trial that was published about a year and a half ago. This randomized 74 patients between the high pressure OPN balloon versus the cutting balloon. And you can see that with the super high pressure balloons, there is significantly reduced diameter stenosis and significantly higher minimal luminal diameter, although the stent expansion is the same between the groups. Has there been any change in the atherectomy? Well, the atherectomy techniques remain the same. What has changed in the treatment of calcification is the trends in the use of rotational atherectomy. Slightly older data, and we'll review it in the context of recent study, is that the use of atherectomy, despite increased prevalence, has been about 1.1%. And this has gone up to about 3% in 2016. This is the data from the BMC2 registry of about more than 42,000 patients in the Michigan state. And you can see that with the advent of lithotripsy into 2020, the use of lithotripsy as a calcium modification device has significantly increased to about 5%, making it the most commonly used device to treat calcified lesions. The use of atherectomy has declined slightly from about 5% to about 3 to 4%. However, the important thing I want to point out is that the line in cross, there has been an increased utilization of combined approaches with multiple devices to treat coronary calcification because the challenges have been recognized for different subtypes. This is the pooled data from the PREPARE Calc and the IZAR Calc trials, and this data compared the outcomes of rotational atherectomy, modified balloons, and the super high pressure balloons. And you can see that stent expansion, although it was low overall in the low 70s, we want ideally to be around 80%, but there was no significant difference in whatever technique you use. So the important thing to take from this trial is whatever device you use, you have to prepare the lesion adequately. Lesion preparation is key. With respect to eccentricity, a super high pressure balloon had a better profile. The strategy success was highest for rotational atherectomy. That makes sense because many of these balloons have a higher profile. Intracoronary imaging is the key. And that's what many times you're not able to get the catheter across, and that's fine. But if you're able to get the catheter across, identify the type of calcium, whether it's eccentric calcium, concentric, or calcific nodule. And this is a really good paper in which, based on the intracoronary imaging, you can actually tailor the treatment strategy towards the calcific nodules. And although it's a busy slide, it's mainly summarized in this slide. So if the calcified lesion is eccentric, usually the scoring balloons or non-compliant balloons would work. With concentric calcification, rotational atherectomy or lithotripsy is the way to go. However, if you have nodular calcium, the first line is usually rotational atherectomy and orbital. However, there's a data, the OCT subset data from Ziad Ali, which included pooled patients from Disrupt CAD 1, 2, and 3 that actually showed that with the use of lithotripsy, you can create fractures in the calcified nodules and consistent expansion in the stent area. So over the last year, there has been renewed interest in the use of combined approaches, the use of laser and orbital and IVL and scoring balloons, high pressure balloon. And so different strategies may have to be used to modify the calcified plaque. Just want to quickly share this case. We had this patient, 79-year-old with NSTEMI, had a calcified ostial left main. Also, you can see the very severely calcified left circumflex artery. LED is occluded, and there is a patent Lima-2 LED and vein graft to the right. There's a huge calcific nodule in the left circumflex artery. And although the left main artery is severely stenosed, there are areas of eccentric calcification. So in this case, we went with the rotational atherectomy mainly to take care of the calcific nodule and use a 1.5 burr at 160 rotations per minute. Use an angiosculpt with inadequate expansion, but then use a 3 millimeter high pressure Opian balloon that expanded the lesion 3 millimeter in the circ and 3.5 in the left main, and then got a Zion stent potted to a 4.5 NC balloon with a good angiographic and results with the IVUS. There will be updates in the multiple devices being worked on for treating coronary artery calcifications. There are going to be iterations of IVL balloons that are expected. There will be longer follow-up of the Disrupt CAD 3 that we'll look forward to. Bali trial randomizing patients to IVL versus plaque modification. The roller coaster trial evaluating strategies of rotational atherectomy and laser. And the Eclipse trial, which compared orbital atherectomy and balloon angioplasty with stenting, has completed enrollment, so we'll see the results of those trials pretty soon. That's all I have. Happy to answer any questions.
Salman, I'm reassured that it's all you had because it was the longest 10-minute presentation I've heard during the meeting, but you did a good job. So we don't have time for discussion. Let's move on to the cases. I would like to have Ashish come in and give his presentation of a case.
Thanks, everybody. Sorry, the order had to be flipped because I have a flight to catch, so I apologize. Thanks for accommodating me. So thanks for inviting me, Manos, to a great meeting again. I really had a great time. I learned a lot. So in the interest of time, hopefully I won't take as long. And I think it ties into a lot of the things that Salman talked about in his presentation. So this is a 65-year-old He's a South Asian psychiatrist who works at the VA in the Phoenix area. Basically started having some chest burning when he was riding his bike. He reliably rides for about 30 minutes. He then has to slow down because he has this exertional chest burning and goes away. He doesn't smoke. He's a non-diabetic. He's on anti-cholesterol and blood pressure meds, and he's pretty well controlled. His heart rate is pretty good at rest. So interestingly, in 2020, for an unknown reason, he underwent a CT-FFR with the heart flow system. And it was his referring cardiologist, I think, that had ordered it at his request. And because of a family history, and sure enough, he had had FFR positive disease in the right and what was thought to be FFR positive disease in the LAD, both of which were medically treated in the midst of all the ischemia data. And he was appropriately managed because he had no symptoms except for risk factor modification. So he did well for 3 years until he started most recently, 3 months ago, having symptoms of exertional angina. So before we get any further, the next steps, let's just ask anybody on the panel what they would do as far as what the next steps are. Would you add a second angioanginal? Would you refer the patient to surgery based on that? Or would you potentially consider the patient for a PCI based on his information that you have?
I think it's a good question. Go ahead. Anybody on the panel would like to take this one?
So the CT was how many years ago?
2 years ago.
2 years ago. I mean, I think you can make the case to cath the patient and see the anatomy, and you can add second anti-anginal until he's scheduled for the cath.
Okay. So nobody's going to send somebody to surgery just based on a CT-FFR from 2 years ago. So we obviously
Will your surgeons take somebody to the OR with just a CT?
My surgeons with the current CT, yes, they are. So if it's 2 years ago, they may not, but
Right.
yeah, they are operating without, because they look at the CT themselves, and if the quality is good, we're a good CT center and have decent quality control, and so they're pretty accepting of patients without surgery.
Good.
So anyway, here's his anatomy. He's got the lesion in the LAD, and then what next? So that's the LAD lesion, which was FFR positive. That's the circ, which I thought was intermediate and was negative 2.5 years ago. So Pervez, what would you do now? Without telling you the FFR results this time, what do you think is going on, or what would you do?
Right, and the RCA is still the same as it was in the CT, or you haven't shot the right yet?
I haven't shot the right yet. That's next.
I think we need to know what the right is, and then I think we can make a decision.
So I just for purposes of completeness, just did a IFR of this because I was not impressed by this angiographically, and the IFR was completely normal. So so much to say for the CT-FFR correlation, but in this case, for some reason, there was literally, I see some proximal disease in the calcified segment. There's overlap. I get that, but the IFR is negative, so I stopped right here, pulled the wire out, and then went to do the right. So here's the right. So let's just get Stephane, how would you approach this? So obviously the CT showed correctly that the right had an anterior takeoff, but I was able to engage it pretty straightforward with a JR guide. And there is no stent. It looks like there's a stent in the very proximal right. He's never had a procedure done before. There's a long lesion in the right, and then there's a second lesion in the right that's just before the crux.
Well, to me, it looks that it's going to be a lesion that's going to be difficult to image first. It looks like pretty tight, and in my comfort zone and everything, I would probably approach this case with a primary rotablation, and afterward image the RCA and decide further on whether I need any other adjunctive treatment after the rota. But that would be my approach. I don't know. What would be yours?
I think if you can get imaging down there up front, that's always the best way to start. I think that helps strategize. But if you're not able to, upfront rota.
Okay, so I think Stephane and I are probably old enough and think the same. So sure enough, so obviously primary roto, and so that was our decision. And so we used a 1.5 burr. I'm still radial. There's no pacemaker. We use aminophylline if we need to, and so that's the plan. So the roto was done. And then what next after that? As Rhian rightly suggested, you want to assess the modification of the plaque after the roto. We unfortunately don't have beautiful images of high-def IVUS because we have an integrated Phillips lab, but you can see there is still work to be done, right? There's clearly an unexpanded stent. You can see the angio pullback on the right panel there, where you can exactly correlate where you are. And you can see right there is where there is a 360 area of calcium that is completely untouched and unexpanded.
You've not deployed a stent yet,
No,
right?
this
You
is
said
a 1.5. This is the 1.5 burr, and then after the burr, this is a
maybe
2.5.
it slipped through your mouth. You said underexpanded stent, but there's
No,
no
this is
stent.
like a 2.5
The
balloon.
plaque
This
is not
yeah,
expanded.
Exactly.
Correct.
So 2.5 balloon.
Okay.
Sorry. So,
Yeah, it was just
To see
making
if you
sure
were
that
paying
we're following,
It
and
does
we're
look
following
like
you very
exactly.
closely now.
Exactly.
So you have this, and what's your interpretation in terms of your calcification? And it looks like it's difficult with the manual pullback, but it looks like this this 360 ring of calcium is probably longer than just a few millimeters, right?
and it's, I think, worse right where the proximal segment is before it becomes like a 3.5 or a 4.0 vessel proximally. I think here there's some fracturing you can see with the 2.5 balloon, but as you get more towards the proximal edge of the balloon, you can see that there's clearly a waist. And so I wasn't happy, and so based on that, the next step we did was we tried an NC balloon to further prep the vessel, and the balloon ruptured. Then obviously we decided, based on what Salman was saying about adjunctive therapies, so IVL, and so the IVL balloon also ruptured. But you can see now, based on that 2.5 balloon that we saw earlier, there's clearly better expansion after the IVL. I was able to deliver most of the pulses, and at the end of it, as we were about to deflate, is when it ruptured. So I felt like we had done something with the IVL, but I didn't quite know exactly what. So, of course,
Were you able to deliver all 80 pulses, or was it when it ruptured? Was it right after the first?
actually, I think towards the end of the last, so I started a little distally, and then overlapped it for my second run, so I got 40 pulses. Most of the pulses were in. I would say almost all. So then I imaged, and as I'm imaging here, he starts complaining of, I don't feel so good. I just start feeling like I'm having some chest pain, and I don't really feel good. And so it was, I think, a 3.0 based on, yeah. So here's a real-time view of what a perforation looks like in, that's the segment right there. So that was a perf, and I was unaware the patient's hemodynamics was stable, and here I was pulling back, focused on the IVUS, and the guy was complaining of some chest pain, and we got a free look at an IVUS appearance of a perforation that I'd never seen before. So if you really pause and see where the dye hang-up is on the right side of the screen, we're still in the distal part of the vessel. Keep coming, keep coming, keep coming. No, right here, and then you can see here is the perforation, where you can actually see there's a hole in the vessel, exactly. And so the next shot I take is I bring a guideliner in, and I take a quick puff to see where we're doing, and here it is. So we have a perf, we're still radial, we've tamponaded it, and then the bottom line was we ended up just getting, luckily we had it all IVUSed, we had it adequately prepped, we confirmed that on that image we got, and so I appropriately sized it 1-to-1 based on the distal reference vessel, and then post-dilated it, and then basically put a papyrus in, and this was our final angio. This is, again, the angio pullback all the way from the PDA. I had to stent that distal lesion, which we took care of as well. And you can see there's no edge dissection, full stent expansion, adequate MLA exceeding 5.5 all the way back. We should be getting close to the zone of where the papyrus is, right about here. Kept coming back. All this looked pretty good. I don't see too much wrong here. Here, that's the papyrus. And then back to the very proximal portion. Again, it's full expansion there. The vessel looks like it's adequately expanded, and then we're into the guide. And so that was the case. And so my takeaway is that identifying calcium is not enough. No device is magical. There's often a need for complementary therapies. And then you often need skill sets to handle a complication, because with calcified lesions, as was shown earlier, the risk of complications are higher. For that, you need to deliver covered stents, know how to use ping pong guides, be able to do a pericardiocentesis. None of that was needed in this case, but this was a relatively simple perforation. operation that was easy to take care of, but that's not often the case when you have nodular calcium that exits the artery and creates problems. Thanks for your time. Any questions?
That was an excellent case demonstration. I think calcium is a very humbling part of our career. With that being said, anybody have any key takeaways from that case from the panel?
I think it's a great case, and I think it shows the risk of a calcified coronary artery. And I think I want to say this, and I'm curious in how many people in the audience have this. So I work in a very large health system that has community-based cath labs as well as, surgical-based cath labs. I work in the surgical-based cath labs, so I can do anything I want to do because I have backup. But not all the labs you can do that. So a lot of people feel that, lithotripsy is safe. It can be done in any patient, and you're going to be totally fine. Well, the device may be safe, but the calcified artery is still a calcified artery. And I think this example is a prime example of what can happen with the calcified artery, even if you do everything right. And I think that's a great example and a great teaching point because to take an example, we do fire drills when we're kids in school and stuff like that, right? But at community hospitals, you don't see too many perfs. They don't happen that often because you're not doing those kinds of cases. So when you have one, it's not just the physician who has to be good at it. The staff has to be understanding, where's the pericardocentesis tray? Where are the papyrus stents? Where's all the equipment? Where's the like all these little things that you don't think about, you have to think about. So I think it's a great case.
Actually, one suggestion or question for Ashish and the panel. Great case and great save, actually. So about the guide selection, I was looking at, you start with JR. And except for a typical inferior STEMI, if I'm radial, which most of the time I am, and I see a calcium, I would actually hesitate to use a JR because I know I'm setting myself up for kind of a battle. There's a calcium, I want to deliver equipment, and being radial, I'm going to lose some of the support with JR. So I would go actually with AL. We all know there's some risk, but I was just wondering how many people would actually use JR to deal with calcium.
Can I just comment on that? So I agree with you 100% of the time, but when you're doing rotational atherectomy, you literally need no guide support. You pretty much are actually better off, instead of that AL sitting nosed in, you're better off with the JR because you're having to back in and out of the ostium, and I would prefer to not use, so knowing that I was going to go with the upfront atherectomy option, I recognize that I don't need to be worried about guide support, and with a guide extension, you can pretty much make a JR AL to deliver any equipment.
Ashish?
Yeah. The JR. You can seat the JR.
Yeah.
Yeah, so honestly, classic teaching is actually using less aggressive catheter if you're doing atherectomy, just because you can get, you're weaponizing the atherectomy device and you can get in trouble, but just by using more aggressive catheter. Well, one comment I want to...
yeah, go ahead. Go ahead with the comment.
The sizing of the IVL balloon was based on the proximal landing zone or distal landing zone, because that can make a huge difference in terms of like how using higher pressure balloon, a little bit oversized with the calcium that concentric. That's where this thing can.
So I sized it to where I thought I needed the IVL, which was in the more proximal portion. So I didn't size it based on the distal reference. If I had sized it according to the distal reference healthy segment, I would probably use a 2.5, so that's why I used a 3.0. And I don't think necessarily that the size...
Sorry, Ashish, can you just use the microphone? No one can hear.
I'm sorry, to answer your question, I was focused in on where the balloon was underexpanded, which was in the proximal third, and I picked the size based on what the IVUS measurement was there.
Right, the reason is like the perf looks like was a more distal segment of that calcified lesion. Just that's why,
Possible.
Maybe it's...
Just a quick question. I didn't get if you implanted the DES before your papyrus.
Yes.
And is it usually your practice, and for what? This is mine, but I want to share.
Yeah, no, 100%. Because, of course, to get the best long-term result, it's not as bad as it used to be with the PTFE Geomed stents, but I think even with this, I think if you're going to put in a covered stent, it has to be with IVUS guidance. It has to be with high-pressure balloon inflation. It has to be, if you potentially can have time to put in a DES before you put the papyrus, you're going to get a bigger bang for your buck in terms of restenosis and TLR.
Just quick, I know this is an interventional meeting, but I do think also in a patient who is on one anti-anginal and who has some exertional workload, he's pretty active and has, angina 30 minutes into his exercise, it would not have been unreasonable to add a second anti-anginal, and especially because you know that's going to be a battle, looking at that right coronary. So sometimes I feel like you should take the lesion in consideration and maybe have a conversation with the patient about the increased risk of these adjunctive therapies for calcium because of the compounded increased risk of things like perforation, things like that.
Very well said, and actually that's a great point, and that's why I put that up as one of the options, but having a pre-procedural CTA and an educated physician as a patient, he came with very clear expectations, referred from another interventionalist, specifically for calcium management, recognizing that it was a complex lesion, and even potentially recognizing that he would go to surgery if he had significant disease in the prox LAD. Because you're right, he does not have left main, and he does not have prox LAD disease. He had mid LAD disease and mid RCA disease, both of which can be easily managed medically.
Great. Thank you, Ashish. That was great. Lots of learning points. So now I would like to invite Konstantinos Charitakis to present this case.
Thank you. I think my case is the next one. Yes, there you go. Thank you for this invitation. Thank you all for being here. And I've learned a lot. This conference, very humbling cases. I'll tell you, this is not my worst or my best case, but unfortunately, it's one of the longest I've had this past year. So I'm going to talk about how to treat stent under expansion due to coronary calcification. And disclaimer, that was a 3 a.m. case. I have no disclosures relevant to this talk, but this case of a 48-year-old gentleman, he came with chest pain, and he was found to be hypotensive and tachycardic. Diagnosis of admission was NSTEMI and cardiogenic shock. In his cardiovascular history, he had history of diabetes, hyperlipidemia, and he told the fellow that he had 2 stents 6 months ago in a different hospital. He also said that he stopped his Plavix last week because his primary care told him that he already had 6 months of dual antiplatelet therapy, so he was only on aspirin. His chest had chest pain on and off for the last 3 days, and I'm in Houston, Texas. You know, a BMI of 42 is kind of the norm. So this is the cardiac angiogram. We went radial. We kind of felt that, you know, we should go up with a guide. And you see severe ostial LAD disease and severe CIRC disease as well. Given the size of the patient, you know, we weren't 100% sure where the stents are, but if you look a little bit closer, you'll see that, you know, there's stents in the prox and prox LAD and the proximal CIRC. At this patient, at this point, the patient continues to be hypotensive. We started some dopamine, and you know, we decided to take a closer look and see what exactly is happening here. As you see, you know, the IVUS images, you see a stent. It's a little underexpanded, and then closer to the ostium, you see a circumferential calcium around there. Distal vessel is almost like a four vessel, and you see the calcium in that stent. And actually, the CIRC we IVUSed as well. And I don't know how they managed to miss both the ostium of the CIRC and the ostium of the LAD, both calcified. But so the clinical challenge of the case is, first of all, what to do. The guy's in cardiogenic shock. You also saw the lesion. You saw the underexpanded stent. Doesn't seem like an easy lesion to treat right away. Should we use some, first of all, should we do something? Should we use some support or not? Should we do the case tonight at 3 a.m.? Should we stay radial? Should we go to femoral? And, you know, what's the plan? We know that this is not going to be an easy lesion to fix. We see the heavy calcification behind the stent in the ostial LAD. I'll be honest, you know, it would be easy, like maybe we put an Impella in and let the guy cool off on heparin and see tomorrow. I just didn't feel that this guy's going to do well, given I didn't know if there was, if he was going to turn the wrong direction. He didn't look good. So, you know, we decided to do a right heart cath. He had a cardiac index of 1.7, wedge was 28. And, we decided to do the case at that point. We said, let's just try, see if we can expand that stent, see if we can, try to make him feel better. Regarding the radial or the femoral access, I would have stayed radial. Unfortunately, the IVUS was so difficult to get it through the lesion. You saw it was like, for a vessel, was less than 2 on IVUS. So I decided to go femoral access. I was also worried that in case, we need more support, we may as well have access in the femoral artery. And, regarding on how to treat with, this lesion, we already had the algorithm in place by Dr. Brilakis and, this paper in December about balloon antilatable lesions with in-stent. So the algorithm says, start with high pressure balloon inflation, 1-to-1 or undersized, 2 undersized balloons, and, use more body wires if you need to, and then start modifying the plaque if you have to, and that can use Wolverine, angiosculpt, or chocolate balloons. We don't have those, but next step, the IVL or the very high pressure balloons. Next step, laser or atherectomy, and if that doesn't work, we can send the patient for cabbage. Given the fact that the patient had the fresh stents, I would say like less than 6 months ago or so, I wasn't very excited to, do any sort of rotational or orbital atherectomy. But, we had the rest of the toys in the lab, so, we started. And, we started with serial non-compliant balloon dilatation. We went high pressure. We got Wolverine. We got angiosculpt balloons. But, as you see there, you still see that spot is very, persistent. And as I said, it was a very long case because every time we were doing some sort of balloon angiosculpt, we say, well, let's just take a look in the eye. Is there any change? Have we done any modification? Unfortunately, we didn't, as you see here, we pretty much the same. You still see that spot there in the osteal-AD that is, pretty bad. And then we got the, the lithotripsy 3.5. We averaged one more time. We saw some difference in 4.0. And at that point, we did both the left main into LAD and the circ. And at the end, with the kind of 4 non-compliant balloon, we went up to like 22. And then we finally saw in the IVUS, better result. And at that point, since we saw the IVUS that we're able to modify the lesion, we proceeded with bifurcation, stenting. I have to admit that during the IVL, the patient, did have VT. We had to shock the patient. So then we proceeded with a quick Q-lot, and the final images, we got a pretty good stent expansion in the osteal LAD. His clinical course was uneventful. We pulled the balloon pump next day. He was discharged 3 days later on GDMT, and it's a recent case. We have a plan for a cardiac PET stress in 6 months to evaluate his the patency of the vessels. For me, the learning points of this, number one, the use of intravascular imaging is key pre and post intervention. We did a fair amount of passages with the IVUS catheter after every modification we're doing to see our intervention results. We needed to have a plan. We have an algorithm to follow, and obviously, depending where you are, have all the toys available because, for example, if the IVL was not working, I was going to go laser next and see. Thank you for your attention.
Great talk. I'd like to poll the panel. Are you all comfortable with IVUS in this case to start? Personally, I would have been scared. Like, I know there are like lots of data to start with IVUS, but this lesion was very tight. The patient was unstable and hemodynamically. I agree. Ideally, you do it, but I think in this case, I think you had a good idea what was going on. You could have started with balloon and then afterward assessing, right?
Yeah, I have to admit that I used the 2.0 balloon to open up a little bit and then have the IVUS. That was not going to go on my eyes. So I'd used the 2.0 balloon to open up a little, and then the IVUS went in.
Okay, that makes more sense because it must have been like very difficult because it was already tight. Any comments? Anybody would have considered when you have that amount of calcium or an underexpanded stent, you're considering IVL, how much a balloon pump will be helpful in these cases? You said that the patient had at some point some hemodynamic instability, VF and everything. Could this have been better prevented with some other kind of support? I'd like to hear.
Excellent case and excellent outcome, really great job. But I would say that, approaching these cases systematically, I would say once you put a wire in, an iris or a balloon, you're committing to fixing, right? And this is a case where for sure I would have put Impella in up front if I'm committed, maybe even if I'm not actually, if he's in cardiogenic shock with this severe disease, Medina 111 complex lesion. This is like Impella in, calling the surgeon, and then discussion, because once you put a wire in, this can go really south really quickly. Then the calcification, it's a complex lesion, like you're committing to possibly, in my opinion, when you have time, DK crush. Obviously, this is a emergency, so culotte is the best to kind of save for more like efficiency. But he had ISR as well 6 months ago. We don't know exactly the mechanism, maybe under expansion, but this is complex lesion that I would not, especially in a patient that in shock, Impella upfront, some discussion with the surgeon, and then knowing you're committing to a complex, PCI.
Yeah, thank you. Excellent comment. And maybe I'll say about I have to admit that whenever we took, and I should have shown a picture of his femoral artery, the balloon pump, like the 9 French sheath looked okay. But I believe, for me to put a 14 French sheath there, it was kind of tough to pass through. I actually thought about it because I would have stuck exactly the same sheath to put also my guide catheter and do my intervention. It's just, it was kind of tight. And also, whenever we ask the patient about, you have such complex disease, did they offer you CABG? He said that at least in the outside hospital, he was, rejected for CABG. I don't know if, with the clinical presentation that he had in the shock state, if any surgeon, at least in my hospital, would have taken him. So I felt that at that point I needed to do some sort of intervention. But excellent point, thank you.
I mean, to be fair, the reason why our Impella balloon pump trials for high-risk PCI and shock are negative because of cases like those where you would think the Impella would provide better support, and half the time we put them in for ourselves to make ourselves more comfortable, but you get away with it. And this is with doing IVL treatments that take time and doing a culotte. And so you did a relatively complex situation and you got away with it. And so I think that's why our trials are negative, because you have enough of those patients who really counteract the really high-risk patients that may benefit from Impella. But me myself, for sure, I put an Impella in, but I know that 50% of it's for myself, just so I'm more comfortable. I take the time that it's necessary to do a DK crush. There's no way I'm doing DK crush without an Impella in most of those patients. But kudos to you. I think, the world that we live in, most cases are done like that without Impella, and they get away with it.
The beauty of your case, too, it shows us we have different tools in our toolbox to treat calcium. If this was a patient that needed atherectomy into both branches, they may have gotten sick or sicker than just requiring the balloon pump. So I think it was great that you put the right heart cath in up front, too, and you kind of knew what your pressures were, and you could reevaluate them through the duration of the procedure. So overall, great case, great result.
All right. So let's move to our next present.
Dr. Kathleen Kearney, please come up for your calcification.
Going to say I don't know who that is, but I'm Kate. I'm from Seattle, Washington. I have another calcium case here. Here are my disclosures. And so when we were chatting about different options, I think Manos had asked me to present one that was a little bit different than our usual. Obviously, we do lots of atherectomy, lots of kind of upfront stage approach for that. In this situation, it's a case I'm not particularly proud of, and you will quickly see why. So this is an 81-year-old gentleman. He's status post-CABG. I think for the purpose of just expediting the case presentation, I'll ignore his other together quite complicated anatomy. So he actually came to us because there was concern that Circ CTO with really undefined target was potentially the culprit. And he is one of these active guys in the Northwest. He really wants to hike. He's going back to his native Scandinavia soon. He's really frustrated by his symptoms. But we weren't sure that we had an easy target. And he'd actually had an angiogram a year ago with basically this ill-defined Circ territory. So we repeated his angiogram because he felt like his symptoms were getting worse. And largely I was highly motivated to find something that we could do to get him kind of back on his feet. So try to get this left-sided image to play. So he's got a ramus here that had previously been grafted and stented proximally that had some ISR that had been observed in the prior angiogram. And so we said, well, there's a little bit something funky there. Everything else looks exactly the same. We don't have any collateralization of the circ and an OM that we suspect was grafted at one point. We're working on getting old films, so why don't we IFR this? It's 0.81, and he has a very clear step up right at the distal edge of the stent with some ISR that's also in the distal portion of that. So I'll say I don't do a lot of OCT, so we look for opportunities to use that from a training standpoint and also for myself to get better at that. But we certainly saw some calcification here, and we sort of see the target of interest. The last time that this had been stented was several months ago, or it was more like a year ago, I think, actually. So to some degree, the stents should be reasonable if we wanted to do atherectomy. But indeed, because it was on the stent edge and it was a relatively large lumen area, these are ones that we've also thought about. Sometimes you need a bigger burr. I worry more about burr entrapment. And to be perfectly honest, I had promised my staff that if I did an ad hoc intervention, I would have them out by 5:30, because this was the day we go to the call team at 5:30. And I said, don't worry, I promise I won't do anything that will keep us here late. So those are famous last words always. So we proceeded with POBO. We tried NC balloons, a Wolverine that didn't look fully expanded. So based off that calcium, we said, well, let's just shockwave it. And this is kind of the advantage of worried about interacting with stents in the distal edge, and it's very focal, so we thought that would work. Based off our distal landing zone there, it was about a 2.8, so we chose 2.5 for most of these things, ended up placing a 2.5/22 stent and post-dilated with a 3.0 at high pressure. But there's one focal area that actually does not look great. It's hard to see on fluoro in a lot of these cases, but actually you can tell that there's an area that when we get to the OCT is quite clear. So, of course, my staff reminded me this is actually 5:18, and remember, I have to be out by 5:30. So, with some dismay, see the OCT run, if I can get that to play, that there's one very focal area, and you can see that nicely with OCT just because it lays that out so quickly. We kind of can hone in right there in that spot that's problematic, is kind of eye-catching. So, I think we obviously did the usual things of take our NC balloon back, went to higher pressure, so we took the 3.0 to 30. There was some shift change going on because I'm keeping people late. We actually, on accident, put a 3.5 in at one point. And this is late in the year, a couple months ago, and so I'm standing in lead behind the fellow who's actually first operator for all of this. Once we put the 3.5 in, I scrubbed in because I just wanted to feel closer to the pain just in case that was a mistake. But fortunately, we didn't cause a perf, but we still had this area of under expansion. So we take a regular 3.0 NC balloon to 30, and we still have this segment that's really imperfect. So I'm curious, kind of from the panelists, what your strategies are for this imperfect stent that I just put in, unfortunately.
I think this is where the open balloon can be extremely helpful. Of course, the practice is to use an undersized OPN. It would have been 825 for me here and go to 40, 45, 50. But you have to go and use undersize for sure, because if you use 1-to-1, you can get disaster. But I think it's a new tool in the toolbox that everybody should get in their lab. Anybody has experience with OPN on the panel? No?
From your experience, OPN versus IVL, again, can you just...
Well, there's currently one trial is being done in Canada comparing to and some preliminary data that has shown that there's no difference in terms of stent expansion compared to IVL. However, the concern has always been like, the use of force, it depends. It will maybe work better on concentric calcium or concentric restriction or fibrous like this on the stent than if you're dealing with eccentric. If you're dealing with eccentric calcium, an OPN will not do any things, and then IVL might be much better for these cases. But here, I think it would have been a good case for an OPN.
And I missed it. Did you say you used IVL already?
Yeah, we had used a 2.5 IVL balloon.
2.5, and based on
Pre-stent.
the OCT sizing was 3.0.
Yeah, it was about 2.6 to 2.8 in the distal segment. More, it was larger, like a little over 3 in the proximal. So we used a 2.5 IVL, a 2.5 Wolverine, and then put a 2.5 stent in post-dilated with a 3. So yeah, I think similarly, we actually, this was after additional post-dilation, we still had a similar issue. The kind of funny thing is you can see the area where we made it a 3.5, so now our OCT looks really interesting in that hourglass shape there, but maybe to keep things moving. So we had actually just got OPN on the shelf that morning. I think it had arrived, or the day before, so was one of those things where I'm like, well, that was good timing, and I think is reasonable, lasing on contrast and things like that we've certainly done, in particular for the brachytherapy cases, but given that we just put this in and worrying about polymer disruption, I felt like this was a good chance for us to try it. I think the points are, we were heavily focused on, having just reviewed this, that you do have to pay attention to the growth in using an undersized balloon. This is the compliance chart from the company, and so they're actually just up to 35 atmospheres. Looking at that, you can see a 4.5 is going to get to be approaching 5.0, and so kind of keeping those things in mind. So we took a 2.5 in this case and went to, I think, 40-something, and seemed to actually look improved there. But I'm interested from your experience, is that too wimpy? How much do you downsize by, and does it depend on your distal reference size?
Well, they recommend 0.5 smaller at what you think. I think your vessel was 3.025 was okay. 40 is probably not enough. I think you can go to 50. That's the point. Like I remember Thierry Lefebvre saying that calcium ring crack at 40, 45, sort of his experience with OPN. Makes everybody a bit nervous at the beginning, and of course, it's a difficult situation. You're at the end of your resources, and you know what can happen at this point, right?
But to be honest, back to the undersizing is the key. We just discussed this in the other case. Like if you have calcium and you're fighting it, obviously you sizing for the reference. But your lesion's still like 1.5, so you're oversizing still significantly with 2.5. So I would just say, yeah, I would for sure 2.5, like half millimeter undersizing is the key for this.
Yeah, I think one thought we had, I don't know if anyone would have used a 3.0, it's sort of because of that transition point and the calcium interaction, would a 3.0 shockwave balloon have behaved any better? I don't know, but since we'd already tried that once, that didn't seem to be enough here. So agreed. I think Rhian, having trained with us, will know usually the next words out of my mouth will, at least the covered stent will deliver well too, because the balloon looked better, but that all looked fine. And I think there's still an area there. It was interesting. We had messed up the stent expansion algorithm because of post-dilating that other part larger as well. So that's contained, but especially because of this error with the larger NC going in at one point, we decided to accept this result. So fortunately, knock on wood, he felt better for whatever reason and was able to go on his trip. But I think that is one of those things of when it's highly imperfect, when to walk away is a challenge, and I appreciate your guys' insight since you've used more of these OPN balloons. Thank you. So I can stop there if you have any more discussion.
Okay, real quick.
I see some people in the room. I see, obviously, Vlad, Canadian. You've had OPN for longer than we do here in the U.S. Give us a bit your sense. You've been using it.
Yeah, I've found it to be very useful where NCs don't work, where IVL doesn't work. Again, the undersizing is key. I've used it in a number of cases, not in many cases, because there aren't that many cases where the NC balloon itself or other technologies won't work. But yeah, you have to be brave to go to those high pressures for sure. I don't think I've gone over 50. I think usually lesions that I've tried crack in the 40, mid 40s. But yeah, I haven't gone as high as 50.
Yeah, I think 50 is really the max. Yeah. Right. Any other comment?
Kate, great case. Did you do any physiology afterward? I think you said you used IFR. Did you do any physiology or any thoughts to use physiology when you kind of were running up against the 5:30 deadline to see if you could just get away with that?
Yeah, it's a great point. I think they really gave me the hook by the end because we were a half hour over. But I was thinking about this case. I can definitely count on one hand the number of times I've done post-PCI physiology. I think this would have been a great time to use that. And in fact, we already had it open and on the table.
Did you really want to know?
No, yeah. That's another piece of it. I think mentally it's like you want to believe it's good enough and get out of there, but I think it's a good time to use it.
All right, perfect. So now let's move to calcification number 4, my worst case of the year, Saroj, Neupane.
Thanks, guys. So I just wanted to share a brief conversation I had with Manas and before I picked this case. And he obviously gave me the worst case of the year. And I asked him, I treat calcium all the time, but I don't know what you mean by worst case of the year. Are you talking about perforation or trapped rota or like drive shaft fracture of the CSI? I haven't had any of those last year. So he said, okay, why don't you pick whatever case you use the most number of devices. So I figured also this case. So these are my disclosures. This is an elderly man with history of hypertension, hyperlipidemia, presented with sudden onset chest pain with inferior ST elevations. This is the left coronary system. As you can see, there's some collaterals to the PDA with severe disease of Alaiti bifurcation. And that is the right, proximal right was the culprit. Surprisingly, I was like, oh, when I saw that picture, it's nothing gonna go. I'm gonna have to do rota in this acute setting. But surprisingly, I was able to take the 3.0 compliant balloon and subsequently 4.0 NC and 4.0 IVL, put a long 4-5 onyx stent, and that is the final result. As you see, the PDA has some subtotal occlusion. I decided to leave that alone at that point. So brought him back for a Alaiti diag bifurcation a couple days later. So some of the challenges I highlighted over there, any thoughts from panel or anybody in the audience?
At this point, you don't have evidence yet of like severe calcification, right? You're just saying challenge in wiring, right? So you.
Yeah, so I guess just him being an old guy and knowing the RCA was heavily calcified, requiring IVL for a calcium modification. So I suspected, but except some angiographic calcification,
so
I don't know.
This looks like challenging wiring because of bifurcation, tight lesion. I tend for these cases to like be patient with workhorse wire as much as possible and just reshape and use microcatheter if needed. And then after that, if you're able to deliver the wire and maybe even wire it into the diag, you can dilate a little bit and image.
This angiogram is from the original angiogram, right?
Yes.
Okay, so because you would not expect collaterals going to the PL branch, right?
No, I didn't take a pre-angiogram when I started working on the left side. That's why I just had this picture up.
Okay.
Yeah. And it's a diagnostic catheter also. Any other thoughts? I guess I'll keep moving. In terms of the wiring, I didn't fluorosave any of that, but obviously microcatheter because, and use a workhorse wire. I thought the wire gonna slide into the diag just because of the angle, but just to my surprise that it easily went into the LAD. I said, okay. Then I wasn't able to advance the microcatheter. That's the 1.0 balloon you can see along with the guide extension. I had already dilated with the 1.0 and then couldn't advance the microcatheter, so I decided to do a BAM at that point, which is basically rupturing a balloon. Then after that, I was able to advance the microcatheter, which I was able to save, fluorosave that, which you see I passed the lesion, then exchange for atherectomy wire. Anybody use orbital in this case, or you just use rota because it's such a tight lesion? Any thoughts?
I would tend to use rota in this situation.
Well, you've used BAM, you said, right? Yeah. So you could probably just sometimes if it's unlikely to be able to go with a big balloon, but you could. I call it like lesion palpation, right? If you go with the 2.0 balloon and you expand at low pressure and you see it's quite constrained and everything, it helps also take other measures afterward. So you don't necessarily have to lose the opportunity to do a rota afterward. I don't know if anybody performs like this or do this. It's very old school, maybe. I see I see Vlad doing this. It's sort of an old school prior to IVUS. approach, but still helpful sometimes.
Yeah, Stephane, you're absolutely right. I do that all the time today, especially in a case like this where you already did BAM. At that point, 202 balloon and see what you're dealing with, and you'll know in about 30 seconds what you're dealing with, and then you can figure out what your next steps are. When it comes to rota versus orbital, I think it all depends on that. That's usually how I decide it. If it looks that concentric, if my 2.0 balloon doesn't want to cross, then I know the answer to the question.
Yeah, so great point, but I knew the balloon not going to cross because my microcatheter, I had to work really hard to even get that down. And you see the guide almost prolapsing into the aorta, so I didn't think the balloon going to go, and I think that I have to start atherectomy. At that point, my initial thought was, since I had to do a BAM to exchange the wire, and there's a proximal lesion also, which is a big artery, and I can just use orbital and just use low speed distally and high speed proximally. I decided to do orbital.
Can I make one comment here?
Yeah.
So in terms of the choice, because you asked a question about rota versus orbital. So you did some ballooning, and right?
Yeah, balloon with one also, yeah.
Yeah, there might be dissection already that we're not seeing. At this time, it's behaving like clearly calcified, maybe looking more calcified. With angulated lesion like that, with prior pre-dilatation and possible dissection, I would say rota.
Any other
Not
thoughts?
orbital.
Yeah, I guess I did make a wrong decision. You can see both orbital and rota in those pictures. So, I did an orbital, started off orbital, did about 7 runs, but I wasn't really able to engage the actual calcium because of obviously the design of the device. The nose cone actually engaging the calcium, but not necessarily the actual orbit or actual burr. So after about 7 runs, I decided to take it out. What it did do is like my microcatheter exchange made it easier, so swap it out for a rota wire, did a rotational atherectomy with 1.5 at 180 RPM, 180,000, I should say. It did take a while, but ultimately we were able to cross. And then this is the IVUS right after the diagonal. You see that the calcium is still concentric, that after pre-deal with the 3 NC balloon at 26 atmosphere, still calcium hasn't fractured. So at that point, I decided to use 3.5 IVL, which you see looks reasonable expansion after the bifurcation. So did the story I didn't tell, just in interest of the time, that the diag was actually very difficult to wire. I had to use an angle microcatheter. So initially I was going to do provisional into the LAD, but since the wiring a diag took forever, so decided to do a 2-stent technique with 2.515 into the diag and 2 long stents into the LAD, and that is the MSA I was able to achieve just after the diagonal. That's where the heavy calcification was. So I guess the learning points from this case, we kind of highlighted most of it. So it's obviously a significant challenge, and majority of the time we end up in a problem both during the procedure as well as long term because of the calcium, and sometimes you may need to combine multiple tools to get the optimal result. And orbital atherectomy is actually, it has happened to me now. I think this is my 3rd case where I try to do orbital where lesion is very tight, even difficult exchanges with the microcatheter. It may not be the best choice. You may want to start off with the rota. Thank you.
For your worst case of the year, that was pretty good, so congratulations on that. Any comments from the panel?
Can I ask a question for everybody? Actually, what's their experience? Did they encounter CSI and then they had to rescue with rota? Because it happened to me before twice. So I wonder if anybody in the audience or the panel can, or everybody can comment on this.
I think that was the whole point. I think what Stephane's comment earlier with the balloon was that if you're having a hard time getting a 2.0 balloon, the nose cone will engage the lesion, but because the orbital atherectomy is about 15 millimeters back from it and it's not front cutting, you're not going to get it in. And I love orbital atherectomy. It's not a knock against orbital atherectomy, but in cases like this, it's probably not the ideal choice. So this is where I think rota really has its strength, is that true concentric, very tight lesions is where if you pick the right burr and you don't have to go down to a 1.25 burr, that's going to get stuck. So keep it 1.5 and higher, and you'll probably get a great result out of it, just rota. But this is where if you use orbital, it'll fail. And it's almost reliably fails in these very concentric calcium cases.
What I've learned over the last 10 cases is that, the best place to leave an orbital burr is on the shelf. It's with rota, when you use a 1.5, you get a 1.5 hole. With orbital, you just don't know. And that's one thing I've learned from, I have colleagues who don't touch it anymore. I've made my own opinion. Now I'm done with it. But one thing here, what I would have been very, very scared is the fact that when you can't cross, your crown is actually burring proximal, and you may increase the risk of having a perforation proximal to where you have the most resistant plaque. So that's one other reason, that because you keep rolling, you keep turning, and instead of moving, you have more ablation proximal to where your lesion is the tightest. So when you think about it, you're probably risking more perforation in such cases. So I'd be very worried of an orbital device that does not progress and staying long on this. Anybody has this experience with an orbital, or whatever? Am I unlucky with orbital? Maybe, but definitely had issues with that.
Can I just say, so I think the tendency when orbital doesn't cross to increase the speed, or that's what we normally do in rodal, or go high speed, or we keep going up. And that's the common mistake I think we make when we do orbital. I also, Professor said, I love orbital, and I probably do more orbital than rota, to be honest. So with that is, be patient and stay on low speed. Don't go high speed. If you go high speed, even it doesn't track 1-to-1, then you are ablating more. Whereas if you stay low speed, you are in proximal AD, it is almost 4 millimeter vessel. I wasn't really worried about that. I don't think, and also you can hear this tactile feedback once you do enough. You can hear the auditory sound as well as tactile feedback, whether you are actually making progress or you are not touching anything. You're probably basically just you're spinning in the lumen without doing that. But that is a danger if you can cross and try to increase the speed and do it at high speed, that you can create a proximal perforation. So you'd never want to do that.
So Stephane, I'm going to push back on a couple of things that were said. I thought that was a great case. But one, I would say that there's a reason that the term has changed over 15 years from calcium debulking to plaque modification, right? Because we're not really debulking anything. And I would say that just because you don't get a 1.5 millimeter lumen with your orbital atherectomy doesn't mean it didn't work, right? The goal here is to change the compliance of the vessel to allow your stent to expand. And I think we should be careful about assuming you need a second calcium modification device just because there's still calcium on the ultrasound after you're done with your first device, right? The idea here is to create fissures or little tears in the vessel in some way to allow your balloon to expand. And you may see that with OCT very commonly. You may not see that on IVUS or with other technologies. But if you're really, there's nothing wrong with trying a device, still seeing calcium on IVUS, and then bringing in a balloon and see whether it expands to decide whether you need to go to the next step or not, because very commonly you don't.
Yes, I think this case, as well as the other cases that we've seen so far, just highlight the fact that each device has its pros and cons to it, and it's using the right device for the right vessel. Okay, in the interest of time, let's move on to calcification case 5, my best case of the year with Andrew Klein.
Thanks so much, and thank you for the opportunity to be in the coronary room. I'm usually in the peripheral room, so I'm kind of feeling a little out of place here. So I'm going to give you a little bit of coronary calcification, and just like everybody else said, Manos, if you don't like my case, you can blame him because he picked this one out. So welcome to maybe not my best case, but I would say what I thought was the biggest change in coronary calcification with 2 different devices. But I do think the idea of maybe perhaps not bringing 2 devices off the shelf, maybe testing it first is a definitely good point. I'm an interventional cardiologist, but I'm also a perforist. So, this is my brain. It's very limited. specifically on the survival and the oculostenotic reflex is obviously very big, and overall my intelligent thought and evidence-based practice region is relatively low, especially as a peripheralist. So with that, let's move on and look at pre-procedural planning. I think for calcium, I think is critical. We talk about this in the peripheral space all the time because you really need to understand what you're up against before you go and tackle it. And when I think of this, I think more of Sun Tzu's about know thyself, know thy enemy, and 1,000 battles and 1,000 victories. So in the coronary space, it's all about pre-procedural imaging, if it's diagnostic, if it's IVUS, if it's coronary CT, whatever it may be. Try not to get in these cases ad hoc, mainly because they're, unless you have to and it's a STEMI, these are very complex cases that have a high risk for perforation. I think it's important to understand what are you dealing with and have you time to sit out there and plan this before the patient's on the table. For this, it's know thy enemy. It's obviously IVUS. We talked a lot about here with OCT, coronary CTA, and as well as fluoroscopy, and hopefully the case will show this. So here's an 83-year-old, usual suspects, diabetes, hypertension, dyslipidemia, came with chest pain, got a nuke. It was anterior wall ischemia, and my partner basically did a diagnostic cath and said, I'm going out of town. Do you mind handling this case? They've been turned down for surgery. I'm like, well, they're 83, not surprised, multiple comorbidities. You know, just hand off, here you go. All right, so here's their diagnostic cath. Here's the right coronary artery, relatively ectatic region, nothing of interest there. And here's the left coronary system. High-grade calcific lesion in the proximal LAD. There's also this severe lesion in the obtuse marginal. Different views of this, you can see that that is a pretty tight lesion. It may be hard to appreciate the amount of calcium adventitial-wise there, but very, very heavily calcified. And there's actually a lesion in the more proximal circumflex that is a little bit challenging to see as well. And then here's the LAD as runoff, relatively diffuse disease in the mid to distal aspect, but heavy high-grade calcium and kind of a small, moderate caliber diagonal, which I didn't want to lose, but I also didn't want to get into a bifurcation stent strategy in an 83-year-old. I think time is also of the essence. That's when bad things start happening on the table. So fortunately, we're dealing with this for an LV gram. That made me feel a lot better about this case. But you can see I think this is a great picture because you can see how much calcium there is up there. 83 years of good old calcium. There's no stents, no single stents up in that LAD. That is all good old 83 years of southern living. So my plan was to go circumflex first in case I needed to deal with something, use IVUS guidance, which we do for 100% of our cases at Piedmont. Maybe try LAD rotablade initially, IVUS, and then decide whether or not we need to go back with a shockwave. I'm going to try this 6 French radial and try not to get into anything and get in and get out as quickly as possible. So here's a series of the circumflex, which I won't bother you with. There's no big issue here. We put a 2.534 resolute in the obtuse marginal. We post-dilated the 3. There's actually a lesion up in that proximal circumflex. We'd use a 4x15, which is a little bit hard to appreciate. So that's where we sat at the end, which now I think you can see the calcification at that ostial LAD that is not small. So that's our final kind of, all right, circle looks good. Let's move on to what we're dealing with here. So post-PCI, here's the angiogram. You can see good flow down the circumflex. Everything's looking pretty down there. So let's go through with the 1.5 millimeter burr. I also think that plaque modification is the proper term here. I don't use a lot of orbital anymore, and I definitely don't use it on high speed because every perf I've ever had has been on high speed, so I won't do that anymore. And I don't like filling out those forms for the papyrus stent. Here's the LAD intervention. Again, we're going to go right with IVUS right off the bat here, and I think I have a copy of the IVUS here. This is what you're talking about, concentric calcification throughout the entire vessel. This was shot with my iPhone because thanks to our new privacy laws, I can't download a single thing from our systems anymore. So I think you can see here and appreciate there's 360-degree arc of calcification downstream. We're not going to get into that area, but you can see the substrate that is present, that it's clearly concentric. And as we pull back here, you're going to see the critical lesion at the ostial and proximal aspect of the vessel right there. And you're going to see that you can't even see beyond it. It is completely calcified, and there's very little lumen. By the way, this is after rotablade. So hopefully this has been modified. Obviously, you're not going to see a lot of debulking there, and as you can see, this plaque extends all the way back up into the left, kind of right before the left main. So with that in mind, I decided to pull the trigger and go for a 4x12 C2 shockwave and braid this out. This is the shockwave treating this area in here. going up to 4 atmospheres, and then going up to 6 atmospheres. That's what the angio looks like as we come back. That's the balloon. It actually did have initially a waist on it, so I was happy that I brought that out versus just trying a non-compliant balloon, because when you're starting to get a waist at 4 or 6 atmospheres in the shockwave, I know I'm doing the right thing. When you see it release, everybody feels better, or it's time to pull out the papyrus, depending upon what that release looks like. And so this is what the angiogram looks like after. Can't really see it, but you can see that the proximal aspect looks a lot better just after shockwave. We said that you can't just do balloon angioplasty anymore, but we obviously are not going to do that in 2023. So it's all about sticking the landing here with this. And of course, everyone's like, can you just stop moving for a little bit? As you're trying to position this, fortunately, I think we were able to do it. And then we aggressively post-dilate it using a series of balloons and went as high as you can see the waist there after, again, Rhoda, after shockwave. Now coming back with a 5 millimeter based on intravascular ultrasound sizing, non-compliant balloon taken to 18 atmospheres. And here's our IVUS final. I think you're going to see that the stents are well expanded. Again, we will have our papyrus in the room just in case there's any issues. This provisional stenting only, I left the diagonal. Again, at least I haven't seen anyone die from a diagonal, so we're going to leave that and just deal with the LAD. I think you can see the stents are well expanded throughout this region using a combination of calcium modification techniques. Again, Rhoda with this, and we'll go into the final. Just going to let this roll all the way back. It looks like we were able to stick the landing, which was nice, just prior to the takeoff of the ostium of the LAD. As we come back here into the left main, this will actually speed up. And, all right, just take my word for it, it looks good. That's the final angiogram here. So when we asked for the best case of the year, I thought before and after, this was the most impressive that I've seen a vessel go from around 1 millimeter, 1.5, maybe 2, up to 5, without a perforation, without any contained perforations. I thought that this was a good response to using 2 different devices for this. This is the final in the ariocaudal, and again in ario, more in the cranial view. So kind of showing the takeoff. And I thought this case illustrated a good aspect of using 2 devices to modify your calcium and hopefully get the best response for this patient. Thanks so much.
I just have a question. What made you think that this vessel was 5?
The IVUS showed that.
What's your interpretation of IVUS to say that it was 5?
I'm not going to roll back and do that, but when you look at the sizing of this vessel, 5 to 5 for EL was really probably the best that I mean, your first pictures after.
Within the lesion segment, not your reference.
It is very hard, obviously, right after the Rhoda to see where the vessel was, because as you saw in that IVUS, it was very, so what you don't see is that in the middle of this, I would
So just the point that I wanted to make is that we often make that calculation within the lesion segment, and there's a Glakov phenomenon. And although you got away with a beautiful result in a super large vessel, I doubt this LED was 5.0. I think it was a 3.5 to 4.0 because it's a Glakov phenomenon. And then, okay, it accommodated your 4.5 and 5.0 balloon.
I think there's also positive remodeling that happens in these patients many, many years prior.
Yes.
So when you talk about in that, I think one of the things that where IVUS makes a difference, and I respectfully say yes, you got to go, you don't want to go, if your downstream vessel's 3.5, you sure as hell don't want to go with 5 because you're going to be asking for a problem. But I do think when you talk about positive remodeling in these patients, it does happen so that you're setting up, that perhaps allowed me to get away with it, but I think it also allows you to have an understanding that if we don't expand that stent well, I think you're going to be set up for a restenosis, and I think that's where IVUS guidance makes a difference, or OCT guidance. Whatever.
Beautiful result. Any comments? It's so difficult. Sizing is always a challenge when you have diffuse disease, when you have bifurcations downstream and the bifurcation upstream. So what is the real size of that prox LED? God knows. How do you interpret the IVUS data with the angiographic data, and how can we guide people to size appropriately?
Yeah, no, your point's well taken, and I think, first of all, great job, Drew.
Thanks, Perfect.
And I would say that the question I would ask before I answer your question, I'll pose it to you, is that any reason to not just go with a 3.5 or 4.0 NC balloon before you pull the shockwave out? I've noticed at least, and I can't say this for every case, but a lot of cases, it tends to work, and it tends to actually do a good job. And then I'll take to answer his question is that I think we have to be careful in how we size on IVUS in lesions because I think I've seen, there was a case actually presented at SCAI in one of the sessions, the Brazilian session, where that's exact same case as you, and I was just cutting to him, I was like, you got guts to do what you did, because I'm not sure I would have done that, because I'm always worried that's going to perf, especially in an 80-year-old, that's right. So, I mean, it may be the right size, but it's just, you know, I try to stop at my MSA where I think I got a happy balance between lack of restenosis and no perf. And I'm not sure there's a right answer to that, but I try to walk that line.
So to answer your question, I've done both, and I do like to try to use the non-compliant. It's more cost-effective, let's be honest with ourselves. It's more cost-effective to use a non-compliant balloon, and then you got that waste, and then you're sitting, you know, do I want to post-dilate the stent with the waste, or do I want to try up front to use the IVL and just be like, I'm safe, I'm good to go? In this case, I was more concerned, and I don't have no data for this, to say that using IVL up front, perhaps cracking the calcium, perhaps getting a little more ability to expand the stent, I felt safer in pushing it a little bit further. Maybe wrong, maybe right. I got away with it. Who knows?
No, I think it's a great case, great example of the sizing and kind of the algorithm that you use. Another important point that we always tell the fellows, especially in July, make sure to give your nitrates and your vasodilators and everything else, because to your point, Drew, there will be some remodeling. So try to get that thing as big as you can. And then it's probably okay to put in the 3.5 or 4.0, because most of those stents go up to 5 now if you want to. So you can always push that limit there.
I totally agree. I think we undersize stuff. I think the other thing is if you, I think we can argue, is it 4, do we go with 5? But whatever you do, I always fear the 2.5 millimeter stent in the proximal left main, or LED.
God
right?
didn't make any 2.5
Whoever
LEDs.
does that, that's just not going to happen. And we've definitely seen a lot of those, especially in the setting of STEMIs. And so, yeah, use your nitrates and go from there. I'd rather oversize than undersize.
You know, good expansion by definition is over 90% of your distal. Here you probably at 200% or 300%.
He's not going to have restenosis. I can promise you that one.
Amazing. it's quite. I mean, it was a remarkable. Another question. I saw. You know, we have some bifurcation gurus in the room, and you decided, and I would have probably done like you do, but it's sort of becoming a bit of a something people don't like to do it, like nail the ostium. People say that in all cases you should stent across. I want to have the opinion of people. Are people still trying to nail the ostium sometimes? And what was this case a good case to try it? Or would you have gone across the circ? Anybody?
So I'll tell you my personal opinion, and I have no evidence to support this whatsoever, is to say if it is the concept of KISS, if you can keep it as simple as humanly possible, your outcomes are going to be much better, especially in a calcified 80-year-old. So I would have done exactly what you did. Yeah, and I think that if with imaging, you can actually prove that what you did is just fine.
Manos? Manos?
It's been debated quite a bit, but 1 second, I want to say something. And actually I was just texting somewhere about this. I know that some people have very strong feelings about it, but I think it's swung to the standing across. I think I'm with you that most people try to stand across.
Yeah, I would agree that you did a nice job, but it's just as easily that you could have either missed it and the patient takes a breath just as you're starting to inflate. You're going to miss it one way or the other way. The worst case scenario is to be halfway into the circosteum, and you're never sure about plaque shift or coronal shift. If you get significant plaque shift, coronal shift, it's much easier to deal with it if you actually have the stent right into the left main, in my opinion, and that's my practice. Unless I have a clear landing zone, however short that landing zone is. Now here I didn't think we had a clear landing zone with normal vessel.
Yeah, I actually felt like I did have clear landing zone without a plaque shift because I was able to go into the circ, go into the LED, and I could see that, at least this ain't my first rodeo, so I've done a lot of those where you stand all the way back, and I've done some where you just stick the landing. It kind of goes 50. It really depends upon the patient. Yeah. And I like the KISS principle, which is get in and get out as quickly as possible, because the longer the patient's on that table, as an 83-year-old, you know bad things are going to happen.
And you don't need to kiss, by the way. I think that's the other thing that we're getting away from is routine kissing of that you have a normal circumflex, you have great flow, there's no need
The stent in the circumflex was not coming back all the way to the ostium,
Correct.
right? So,
Yes.
yeah.
No reason.
Any other comment?
You know, I was just going to comment. So great case, Drew. I was just struck by how slow you're pulling that volcano back. I didn't know you had that patience in you, but that was the longest
It's peripheral, my
pullback I've
friend.
ever seen.
We're patient. 3-minute inflations.
I do think there's a little bit of, you know, for me, the discussion about calcium modification and ROTA versus this IVL balloon, I think, you know, they're completely different indications for me. I think clearly for me, ROTA is when I can't deliver my equipment. And you'll have stalactites and stalagmites that inhibit your delivery, but once you take care of that with the 1.5 burr, the dilation with an NC balloon is successful 95 times out of 100. And so the idea that we use these IVLs as sort of the first reflex, as you were mentioning, I think is a little overkill, especially with the expense of an IVL balloon. It's tremendous. And so I do think there's still a role for some aggressive NC balloon inflation first, and then if there's a waste, it's not like, you know, the relative contraindication to burring after you've dissected. I mean, you can still, you have a stent there, why not try and post-dilate that with an NC balloon before you use an IVL? And there's no problem with using IVL after you stent either necessarily. But I do think the idea that IVL should be the default for lesions that you believe might be a little calcified, I think is a little overkill. Because I do think, again, I mean, how many times have we taken NC balloon up to 16, 18, 20 and it pops? And you can stent that with good apposition, IVUS guided. And I think the reflex of pulling IVLs, you know, every time you see a little calcification, probably is a little overkill for me. Where ROTA for device delivery is something the IVL is not designed for because.
So message is, you know, trying an NC balloon after the ROTA is certainly something that should be adopted and not defaulting to IVL necessarily if you haven't used an NC balloon, and I totally agree with that. Any other comment? I think we're 5 o'clock, so thank you very much for your attendance.